afternoon. Thank you for being here, and thank you. It is late, so I have tried to prepare something that shows probably my entire life. When I started as a student, and unfortunately till now where I'm getting older, and just to show you how it is important that you pick up the best environment, the best mentors, and try to focus on a research field that reflects then the clinical scenario as well. I have chosen to talk about the airways, and the purpose of presenting this picture is because this is a child that is hospitalized in Korea since almost 2 years, 23 months, and will have a transplant of the windpipe in December in the United States. Just to tell you that this is something that's very important for regenerative medicine, because it is the first time that the FDA has approved an organ transplantation based on regenerative medicine purposes. Why I was very much interested in the airways? Simply because it has a life-saving functions. You know that you can swallow, you can breathe, you can eat, but without larynx or airways or lungs you cannot live. It is a very complex organ. We are here in the department of pediatric oncology, but you know exactly that, for instance, the tumors that are in the larynx are 180 times more frequent than tumors in the windpipe, and that lung tumors are at least 400 times higher than frequency, higher than the trachea. So that means that really there is an immunosurveillance taking place in the airways, or especially in the windpipe. It is very complex. And unfortunately, this is a picture of a Russian soldier that was injured in Afghanistan a few years ago, and this reflects the disease. This is a 21 years one of your citizens that unfortunately has had different and multiple surgeries, and he cannot eat, he cannot speak, he cannot have a normal social life, and you just imagine what this means with the 21 years. And this is why I was very much interested in this pathology, because it is in the neck, and the neck is a field that not that much people want to touch because it's very complex. So for instance, the ENT surgeon, they don't want to go into the lower part because it is very dangerous, and the thoracic surgeons want to go up. So that means that by the end of the journey, only the patient suffers because of the incompetence of the doctors. And these are things that must be said, because, for instance, this patient has been treated and operated on 3 or 4 times. So, but the main reason why I was interested in this type of organ was that it belongs with the brain to the very few 3 organs that was never transplanted so far. And the reason is simply because you have this microcirculation, in the sense that you do not have an artery and a vein, you have a segmental microcirculation that is almost impossible to harvest, to take from a donor and then implant. You can do it. It requires a 16 hours operations and a huge immunosuppression. But indeed, by that time, when I had your age, I started to be very interested in that organ, simply because it was never transplanted. My dream was, well, let's see if we can transplant. So if we talk about the airways, we talk about the larynx. There are indications for transplant in the larynx. Since, for instance, here, this is a patient that has no larynx and a stoma in the neck that connects this orifice to the distal trachea. And you have here benign or malignant diseases that eventually can benefit from this type of transplantation. Trickle transplantation is by far more dangerous and more difficult. We know that we can take out almost 50 to 60% of the trachea by doing simple surgeries, but there are few indications, including benign diseases and as well malignant diseases. So the first laryngeal transplantation was done by Marshall Strom at the Cleveland Clinic almost 16 or 18 years ago, and the patient was willing to have this transplantation because of he was a motivational speaker. He wanted to have back his voice. Unfortunately, the transplant did well, but he was unable to speak again, and he was under lifelong immunosuppression. Now, in the field of transplantation, we transplant the heart, the liver, the lungs, the pancreas, the jejunum, almost the kidney. And these transplants are made for life-saving purposes. You probably remember when a few years ago there was this Australian gentleman that had the first arm transplant. After a few years he refused his arm because he has the so-called ghost syndrome. The syndrome that he was looking into his arm and he didn't see his body, part of the body. He was just seeing another arm, and he was under lifelong immunosuppression, so he asked to be re-amputated. Another transplant is the face transplant. These are transplants that are not necessarily saving the life of the patient. So from an ethical point of view, and this is very important, to know it as a medical student or a biologist or whatsoever, when you do these approaches for regenerative medicine, you need to do something that helps the patient, not for cosmetic reason, but just is able to save the life of the patient. So I remember very well when I started with my medical students, and I went to Paris, and I picked up the best surgeon in the world by that time, Philippe Dartrel, who trained me almost 8 years. And then when I came to him, I said, well, I am coming to you only if you allow me to do research. And I took 1.5 day off of all the weeks, including Christmas, Easter and whatsoever. So try to combine this research and clinical activity, because then you can understand how to prevent all the problems and how to solve all the problems. So we started to see whether in pigs we could harvest the trachea. And here we see a picture showing the larynx, the thyroid gland, the superior vena cava, the aortic arch, all the structures that are in front of the vertebral bodies of the neck. Here we show as well that if we take away the muscular part of the esophagus, we can improve vascularization. And this is a pig allotransplantation of the larynx. You see here the larynx, which has been transplanted. And look at this picture here, where you see the transplanted graft compared to the normal graft. There is no difference. So almost 16 years ago, we published for the first time the technique to transplant the larynx and the trachea with the thyroid gland, the part hormone and so forth. But I never did a transplant because from some reason or the others I never saw the right patient. And the main reason was that this type of transplant, because of the very high concentration of soft tissues, needed a heavy immunosuppression, an immunosuppression which is almost similar to the one that you would need to transplant a heart and both lungs. So a triple immunosuppression, and this is not justified for a life-saving procedure. 2 years ago at the University of Dallas, in California. We did the first laryngeal tracheal transplantation. And this was done in a patient that had an awful life. You see here, you should see vocal cords, the epiglottis, and you see here nothing. The patient was not able to breathe spontaneously, was not able to swallow, did not have any smell, and basically the reason was that she was already being treated with a kidney transplantation many years ago, and she has had this complication. But because of the fact that she was already on immunosuppression, she was an excellent candidate for doing the transplantation of the laryngo, the trachea, because she didn't have the necessity to increase the doses of immunosuppression. So the technique was more or less the one that we described when I was a student, and you see here we took out in the recipient the larynx, preserving the nerves and the arteries, and then we harvested in a donor the larynx, showing on the right side panel, and then implanted everything. This is the video showing the vocal cords. You see it right now, and for the first time she had vocal cords, and down the trachea. So really the allotransplantation is technically feasible and can be usable to help the patients. These were the first words. The sound is not on, but the first word after almost 16 years of silence was, "Well, I want to go home." And just reflects the quality of life that you can give to a patient by doing really good things and doing excellent research and clinical activity. Now, why has transplantation of the windpipe, like other organs that are very complex, not become routine? Simply because there are ethical concerns. And if we ask patients that do not have a larynx, you probably have seen them, they have a permanent stoma in the neck, whether they want to have a transplant. This was made in almost 20 years ago, and 80% of the patients said, yes, I want to have a transplantation, but only if I don't need to take immunosuppression. So the first reflex is that, well, patients are very intelligent and do not want the transplant just for coming back to speech, but just to be safe. 50% wanted a transplant when they had a stoma, and 75% of the patients wanted a transplant only if it was completely safe. Now, you are biologists. I was taught that the audience is made up by different type of students, healthcare professionals, and you need to care about your patient, and you need to do it in the best way as possible. And to do it in the best way, you need to respect their wishes. And the wishes is, if the patient feels that he wants a transplant and this needs to be safe, you need to offer them a safe transplant. And that transplantation was not safe. So now we have the technical feasibility of doing a transplant, but it requires immunosuppression. And this was in 96, 95. I started to do xenotransplantation. That means transplantation from animal tissues like the pigs and lambs into non-human primates like humans. And this type of research was banned from the European Union. So I was looking to others type of alternative for these transplants. And this is the reason why almost 20 years ago I came for the first time in contact with regenerative medicine. Now, you know exactly what regenerative medicine is, but just to give you an overview, this is Prometheus, where he was condemned to die by Zeus, but ultimately the eagle was not able to kill him because the liver was over and over regenerating. And why? Well, because the liver has an enormous potential of regeneration, like almost all tissues and organs. So regenerative medicine focuses on the restoration and regeneration of lost, damaged and aging cells and tissues in the human body. And it has two domains. One is tissue engineering and the other one is cell therapy. Tissue engineering tries to replace tissues and organs. Cell therapy replaces the missing and diseased cells. I'm doing this right now since almost a few years. We started to do cell therapy, and I think that cell therapy, replacing the missing function of the cells, is the future of regenerative medicine, not replacing the organs, because this therapy would eventually avoid to transplant a patient, to do a major surgery. Just when you have a patient with not a myocardial infarction but a myocardial ischemia, you already can treat him with specific cardiomyocytes or fetal cardiomyocyte or whatsoever, so that you cannot need a real transplantation. A few years ago, in 2008, we described the first human transplant of tissue engineered organs. And tissue engineering, basically, all the history, since almost 40 years, my mentors, everybody says, well, you need three things. First, you need, in Russian it's karkas, I think, matrix or a scaffold, which can be made by natural tissues or artificial tissue, cells that can be autologous or xenogenic, and a bioreactor. And this is the video clip where the first transplant is illustrated. A patient that came from Colombia, 30 years, mother of 2 children, has a tuberculosis that was not treatable standard. So we took from a donation a human trachea and decellularized, took away the immunocompetent class 1 and 2, especially HLA cells, so that there was no reaction. The decellularization process took almost 23-24 cycles, and then we took the specific undifferentiated stem cells and respiratory cells, expanded these thousands of cells into millions of cells, and then what we did, put the scaffold with the cells into a box where the seeding of the scaffold was made, so that the decellularized previously donated scaffold was recellularized with the patient's own cells. And then we did the first transplant, the most easy part, which was the surgery. Now, when you want to do such new things, you are faced with a lot of problems. And the major problems are the paperwork that you need to fill to get the permissions, whether it is a compassionate case or the clinical cases. So by that time I was in Barcelona, in Spain, and since then we did transplant patients in Spain, in Italy, in the United Kingdom, and in Russia, in Moscow. So the eligibility criteria were these, and the endpoints were biosafety, biocompatibility, graft durability, outcome, and so forth. When I started the transplant, it took me 6 months, every day almost 8 to 10 hours, just filling paperwork, because the major critique that I was addressed was, well, if you transplant the cells, the stem cells that are differentiated in undifferentiated stem cells into differentiated stem cells, the chondrocytes, and then you put it back into the patient, will this induce tumors like teratomas and so forth? Well, I didn't have an answer, but the patient was sick, so we took the risk to do it, and now, almost after 4.5 years, we know that it did not happen. So the transplantation of differentiated stem cells is possible and safe. What kind of patient did we transplant? We transplanted 9 patients so far using biological scaffolds. So just to show you how heavy these patients are, very, very complex patients that need really a multidisciplinary team and an excellent environment to do the transplant. Most of the patients were females, young patients, as you can see here. The youngest was 10 years old. And the type of patients were these, for instance, this so-called subglottic, just below the vocal cord stenosis that was operated already 6 times, therefore benign stenosis. This was the first transplant patient that was operated for a malignant tumor of the airways. This was an awful case of a 28 years old lady coming from the Czech Republic that was pregnant at 6 months, and they treated her with asthma, and then they discovered this tumor. They put the stent, and she wanted to preserve the baby, so we could not do a cardiopulmonary bypass to take away the tumor. She delivered the baby, and then we transplanted her. This was a patient that had no larynx, really with a communication between the trachea and the esophagus. The hole here is the esophagus, or this, probably the most dramatic one, this child of 10 years that had a communication between the aorta and the trachea. That was operated almost in emergency cases in London at the Great Ormond Street Hospital, and now is alive 2.5 years after the surgery. So the type of transplant we did were trachea and left main bronchus. Why I'm showing you this? Not because I want to show you the data, but simply because to show you how complex it is to start from the very beginning a new transplant program. In 1961, when Denton Cooley did the first transplant of a heart in South Africa, and the patient died 1 month afterwards. If one of my patients would have died before that time, I would have been in very huge problems because of the compassionate and because of the fact that it was not life-saving, except for the tumor. So you see that the social environment changes over the years, and you need to be very careful if you want to impose or not impose, to bring in the medical scenario new technique, especially new transplant procedure, because doctors are the most resistant to any, they are so conservative. They don't want new things. So please, you are very, very young. The mean age is very young. Just change the world, because if you don't do it, I'm too old to do it. We needed to take the bone marrow from the patients. Since they were almost adult patients, the mean volume was the one here depicted. The majority of the cells, you can see it, were vital, 95%. And these cells were a mixture of mesenchymal stem cells and hematopoietic stem cells. Put it in culture, they were able to differentiate into different types of lineage, and you need to prove that before you go into the clinic. So don't be a cowboy. Not because the cowboys are coming from the United States, but simply because don't do something without having provided evidence in the preclinical scenario that this works, at least in vitro, in culture, or in the animals. We had one patient that died, others had minor complications, and after 30 days, you see the first laryngotracheal transplant. Tissue, you see quite open, well observing, and this is the Russian patient that had this benign stenosis, is still alive and doing well, and this is patients that have been treated. Now, out from the 9 patients, 3 died from 3 died from different causes not related to the tracheal transplant. But again, the message here is not to list the complication, but to teach you that you need to tell the truth to the people, to the patients, and to everybody. When you do this, you will always have a good impact, an excellent impact, and especially you will respect your patients. So after all these transplants, we stopped to do the transplantation using biological scaffolds. And why? Well, we learned a lot of things. First of all, using biological scaffold, we did not use any immunosuppression. And simply because here you see the DNA contact with the DAPI staining, you don't have cells here, nuclear contact, so there is no potential immunogenicity. And here as well, the fibers include cells. Here you don't have any type of cells, you just have the fibers of the internal and external surface. And this is important. Today I was at the Innovation Forum, and there were a lot of people, especially from companies. They were talking about billions and millions of dollars, and I said, well, if we could reduce, for instance, in the United States market, the cost of immunosuppression, this would be $13 billion, which is a lot of money. Now, at the very beginning, we thought that we needed to take the mucosa of the patients to transplant to the scaffold. This was only 4 years ago. 4 years ago. Because we saw that, well, the chondrocytes are easily madeable. You can differentiate from undifferentiated cells using growth factors like parrot hormone or TGF-beta3. But at the very beginning, we don't see epithelium, respiratory epithelium, because this is much more differentiated. But we see it after 2 months. So if you start a program of tissue engineered replacement of whatsoever organ, you need always to take care that this line here, the basal membrane, is always present after the decellularization, because otherwise the cells cannot attach, adhere, and then proliferate. Now, you remember 30% of the patient had complications. This was a floppy. The trachea was weak. Before implantation, the chondrocytes were on the outer surface, where they should be. Within the first 12 months, there were chondrocytes and respiratory cells. The chondrocytes were supposed to be on the outer surface and the respiratory cells on the internal surface. So what happened? And this is the beauty of regenerative medicine and research. You do a surgery, you have a problem, you go back into the lab and you understand what happens so that you prevent to redo it again into the patient. So using a mathematical and passive membrane model, we detected that in the internal surface we have a higher concentration of PO2, partial pressure of oxygen. Everybody here breathes 20%. On the external surface you have almost a 0. So the stem cells were very, very clever. The one that we were putting on the outer surface were migrating inside to look for better breathing. So the implication, well, very nicely, I started to say to my regulatory affairs department, well, I will not use any more respiratory cells or differentiated cells, because apparently we don't need to do that, in the sense that if we put it on the outer and they are going on the internal surface, maybe there is no way that we need to spend that much money and put all the cells in culture. But I didn't understand the physiopathological mechanism at that time. So I asked my students to work 24 hours a day for all the days of the years, years, and they came then to the evaluation how this works. Now, the trachea is not vascularized. And we can do the same with the esophagus, with the intestine, with an artery. And here you see after almost 4 years how well vascularized is the trachea. So, when I remember I did a seminar in Moscow in 2010 after the transplant. I was invited guest to the Russian Academy of Medical Science. And after this picture, the very prominent thoracic surgeons stand up and say, well, I don't believe you. Okay, why not? Well, this is impossible. You are a liar. Okay, I was very polite, and so at that time I didn't speak Russian. I do speak as well right now. But Then I showed him this picture. Being a surgeon, he didn't understand. This is normal. But I'm a surgeon as well, so please don't take it in a bad mood. The fact is that if you decellularize an organ, you take away the cells, but not the proteins. So if you do an immunostaining, you see this brown staining. These are pro-angiogenic factors. That means proteins that are on the surface here, in fact, between the cartilage and the soft tissue, that increases or induces the vascularization of the organs. And there is only one model in the literature described, that is the transplantation of human tissue into a chicken membrane, so that you produce a xenogenic model. Here, this is a piece of. Thank you so much. This is a piece of. Human trachea that has been decellularized, and here you see after 4 days that there is an ingrowth of vessels. But this is beautiful because it means that as well in patients that have a chronic ischemic heart or legs, diabetic legs, or liver, you can induce the vascularization, and therefore you can reverse the ischemic status of that given tissue and organ. He still didn't believe to me, but by chance we did the transplantation of the Russian patient in his unit 1 year later, and then he believed it. So try to trust it, everybody. We were asked to do cancer patients, so we needed to reduce the timing of the decellularization process, and we succeeded only for about 1 week. Now, today at the Innovation Forum, everybody was very excited about longevity. So, if we transplant an organ, patients survive. Now, even if we transplant it using biological scaffold, here you see the difference between a native trachea, a fresh decellularized, and you see already the difference here in the microscopy, and then a 1 year on the static condition. You see here that indeed the decellularized tissue-engineered organs biodegrade over time, so that it is probably not an appropriate therapy for this type of patients. And this biodegradation is simply because these bundles that give the strength to the tissue or organ are completely lost. Here you see it. You see this is a 2.6 in the native, 2.8 in the decellularization, and then only 1 after 1 year. So it doesn't withstand the mechanical properties and capacity of the given organ. So this was already a negative point for biological scaffolds. We tried to see whether we could reverse this, and we used a genepin, which is a cross-linking agent that if you can use a different concentration and different timing exposure, but basically you increases the size, the duration of the scaffold, the biomechanic of the scaffold. This is the Russian transplant done 2 years ago. But the major problem of biological scaffold is that you still depend on a donation, because you take it from a human cadaver and then you decellularize. You have adult donation, but you don't have children donation. Having a trachea, for instance, or whatever organ into the chest at a 1 day of age is almost impossible, at least in Europe. So the child that I showed at the very beginning, she was born without trachea, and she has a tube here that comes into the distal airways from the esophagus. The mortality here is 99.9%, that's 5 years. So if we don't do something, she will die for just a small tube. And this is the reason why I came across to the fact that probably can we transplant this bottle into a human being? Why this bottle? because this bottle is made by fibers, nanofibers, fibers that are very thin, almost 60,000 times thinner than the human hair, and then can be used to produce three-dimensional structures that can be degradable or not biodegradable. The advantage of using not biodegradable material is that this parallels the somatic growth. But basically, the idea here was using fibers that were more closely and mimicking the normal human anatomy. So this is a decellularized trachea. Here you see given fibers that have a specific orientation, dimension, size, porosity. There is a software that you can study the nanotopography. This is another material, PET material, which has been used in the last transplant. That more or less is the same here. And this is the first transplant. This is a POS material made by Alex Efelian in London, which is an awful material, in the sense that compared to the nanofibers here, these are microfibers. Okay, the difference is very important. So basically, when I started to do this talk and saying, well, I want to transplant this bottle, plastic bottle, into a human being, again, it started, well, this man is crazy. Probably I am crazy, but not that much crazy probably. So these fibers can be electrospinned to give them a dimension like the trachea. You need to test the biomechanics, and this is beautiful because regenerative medicine has a multidisciplinary domain like biomechanics, biochemistry, molecular engineering, cellular engineering, molecular biology, and so forth and so forth. And just imagine that we breathe 670 millions of times in a lifespan of 75 years. And this bottle needed to move up and down, forward and backward, torsion of 45 degrees, 670 millions of times before implanting into the human body, to see whether it will be disrupted, it will maintain the same capacity, mechanical strength. So you see that before going to the clinic, you need a lot of work. Now, let's come to the most exciting part. This is a bottle. This is made by PET fibers. But if you implant it in this way, the patient dies, 100%. So, how is everything going on? It's simply the beauty of these nanofibers is that they permit cell attachment. This is a live imaging study. We have published that in the Science. No, it has been published by the Karolinska in Science. You see that the cells here are attaching to the fibers. There are few cells, then they are elongating, they're becoming longer in a transversal diameter, and then insinuating and going inside to the scaffold. And this in 60 minutes. You don't need to pre-treat this. You can just use the fibers and the cells because they are very biocompatible. And once this cell sticks to the scaffold, they produce a so-called extracellular matrix, where the environment is rich of proteins and their other types of cells are coming into the material. They are able to attract CD5 105 positive cells, which are a specific cells progenitor that can then attract other cells. Now, this was in vitro, and this is the picture of the first transplant in Krasnodar. Thanks to the mega grant, we did succeed to transplant the first 2 patients in June, and these were the first laryngotracheal tracheal transplantation in the world. One day after the transplant, we had progenitor respiratory cells. And then, take care, we just seeded the cells with mononuclear cells, with therefore completely undifferentiated cells. And one day after the transplant, we had these progenitor cells. So I'm still lying? Well, I don't think so, but I will try to explain you what happens. And it happens that we had this chance to have this bioreactor, which is a box, like a shoe box, where you put the trachea here, and then you need to have different type of cells. Well, in Russia, we use mononuclear cells, and this is as well what we are using at the Karolinska. We don't use embryonic cells or iPS cells so far, so we probably will use these for the esophagus and the heart, but not that other type of cells. And then you need to put the two together, and then you will see that the cells attach basically to the scaffold. This is a biological scaffold or an artificial scaffold, where you see that the green stained cells penetrate on the superficial layers and they compete each other. So we need to evaluate from a mathematical point of view and a physical point of view the gravitational axis and everything else. This is how the trachea looks like after the transplant. And this is a live imaging study. You see here that the cells, the hematopoietic and mesenchymal stem cells in red and in yellow-green are on the different aspects of the cells. So we were able to seed the plastic bottle with cells. But what were these cells doing? And this is beautiful. I think that's just creation of life. That's still after so many years, it excites me so much. Look at this cell that divides. See here? Here. So we put the cells on the surface, and these cells were dividing, were proliferating. The FDA required us to see whether the cells were still active after the reseeding process before implanting them, and this is the mechanism by which it was Irina Gulieva, one of the first PhD from Krasnodar within this mega grant that made this study, and hopefully she will publish this soon. We still use TGF-beta3 or parrot hormone to differentiate the mononuclear cells into stem cells, and the idea is like to go in the supermarket. You take one trachea or one esophagus, one heart, and then you implant it. And so that you see here how it works in the very beginning phase, you have a prototype that is adapted to the patient, and then once you have done the surgery, you can still then implant it. Now, I told you that regenerative medicine and tissue engineering has three key components: scaffolds, cells, and bioreactor, right? Right. This was what everybody, or is what everybody else than me thinks, but it is completely impossible. Because we need to tell to the body how to react against a given structure. So the idea here is, before the transplant, to increase the number of the cells that are present in the bone marrow or in the peripheral blood. And then, through the secretion of a stromal factor 1 or 1A or others, these cells are recruited at the level of the transplant. Why? That's a classical example that I do to my students in every corner of the world. If you have an injury of the index of the right hand, this will heal. It will take 1 week, 1 day, 1 month if you are immunocompromised, but it will heal. Nothing happens to the other finger of the other hand. Why? Any suggestion? Who wants to answer? Nobody? Please.
Maybe possible growth factors signaling from damaged tissue.
Maybe what?
Growth factors signaling.
Okay, he has one hypothesis. Who next? Come on. I was told that you are the best of the best. Let me prove.
Can you repeat the question, please?
The question is why the body heals one side and not the same side on the other hand, for instance. Where are you? Because? It's what? Injured. That's closely. The lady did better than you. But why?
These factors are local.
The man did better than the woman, so we are getting closer.
But why would you heal the intact finger? Won't make any difference. There's not such a much link between them. Why would it go?
You are right. Nobody else wants to try? Ah, come on.
Well, it's not one factor, it's a combination of factors, right? It's oxygen, it's the microenvironment, it's the signaling from the damage to the tissue. So it has to be a combination of factors. Well, immune system, of course.
Well, if you say in this way, everything works, right? No, the fact is that the body has the beautiful capacity of a site-specific recognition, in the sense that, as the lady says, he recognized that there is an injury and therefore acts at this level, locally, to heal the process. But nothing happens to this finger, so that means that really the body is able to recognize where the injury takes place. And it's this capacity that we need to use. How? To increase the number of cells that in peripheral blood can eventually induce a homing effect into the site of the transplant. And then use other factors like erythropoietin. Growth factors that in normal condition induce erythropoiesis but inhibit apoptosis, cell death. So if we use high dose of erythropoietin, we will not have the erythropoietic effect, but we will definitively inhibit through this mechanism apoptosis. So if we block apoptosis, the cell death, we promote, we boost regeneration. And this is what happens in the transplant patient, even in the patient in Krasnodar. So there are no ethnical differences. After 1 day of the transplant, you have an increase of the anti-apoptotic activity in the peripheral blood of the patients. I spoke about biomechanics. So we have fixed the cell component, but here this is a three-dimensional CT scan where the trachea that has been transplanted here is shown completely incorporated into the body after 1 year of transplant. So this plastic was able to be accepted by the patient without having any other major complication. And if we look inside, this is before the transplant and the tumor here, and this is after. Can you see any difference between the two? No, I cannot. So really you can produce almost everything similar to the normal windpipe. And here again, the vascularization that took place after only 2 weeks of the transplant, and the epithelium. So this was amazing, an amazing discovery. We did not use mucosa, we did not use specific differentiated cells, but 1 day after the transplant, using this plastic material, bioartificial scaffold, we were able to see respiratory epithelium and progenitor cells. Why? This was made in collaboration with the University of Aachen in Germany, where the stem cells in the peripheral blood express the MIR449A, which is a specific receptor that only the stem cells that then differentiate into respiratory epithelium have. So really, we are able, not only because of the transplantation, because of the use of growth factors, but especially because the interaction of this strategy to selectively recruit and promote the differentiation of the undifferentiated stem cells. I'm sorry, it is almost 10 o'clock, I apologize for this, but it is quite complicated, but very easy. In the human body, you can differentiate stem cells into the desired cells that you want to have, repairing that organ or tissue. That means that probably in the next 50 years, when I will be retired, there is no need to do any transplantation anymore, but just to replace or to try to restore the function of dead cells. And then we are coming to the second or third slide, where the difference between tissue engineering and cell therapy is made. Patient has a normal function. We are still working very hard to avoid the major complication that we have seen even in the 2 patients from Krasnodar, the granulation tissue, but probably this is related to the type of material. What are we doing in our lab in the Advanced Center for Translational Research in the Karolinska? We are investigating all the tissues and organs in the human body from a nanotopography point of view, because we want to produce the most closest material that is to the human body using electrospinning or organoprinting. And this is the post material, the first material that we use. You see clusters of cells attaching to it. But if we use these microfibers, if we use nanofibers, then you see how the difference is between the cell components and the distribution, much more beautiful. And this finally ends up with a more healthy tracheal transplant, as we can see here under these circumstances. And this probably will help us to manufacture tracheas, or, as I said before, just going to the supermarket and then buying some organs. This same concept can be applied to the lungs. We are trying to, I'm sorry. Oh, this is esophagus, which probably will be the next transplant done. This is the heart. You can see the aortic valves. This is the idea to produce a so-called pacemaker of the lung, in the sense that a small box that, instead beating the heart, permits the gas exchange outside the body for patients that have chronic insufficiency of the lung. And these are the 2 new projects done with within the mega grant project as well. The brain, deserize the brain. It's not that we want to make more clever people, because this is impossible, but still for soldiers that have defect, or patients that have a surgery that have a defect of the brain, having a matrix that permits the cell ingrowth will restore the normal function of them. And this is the biliary tract. So I would like to finish this presentation by thanking everybody, and I hope that it is not too late, and I'm open for any questions. Thank you.